Hi, my name is Vivian, and I'll be presenting my team's work on the cost effectiveness of racially concordant staffing. So the inspiration for this project came from the fact that patients from underrepresented groups in the US experience the effects of unconscious bias in ways that perpetuate health inequities. One solution that has been proposed is to increase diversity in the healthcare workforce, which has the potential to improve outcomes, patient adherence, and most importantly, patient experience and trust of the health system. However, there's very little research exploring the financial implications of such changes, which pose a barrier to widespread adoption of more diverse staffing plans. And so my team wanted to answer one key question. Is patient-provider racial concordance cost-effective? In other words, does it decrease costs and improve outcomes to have patients and providers of similar racial demographics? The method we used was a Markov model of cardiovascular disease, a common chronic disease, and we modeled it across a typical primary care clinic in Michigan. We accounted for the costs of treating cardiovascular disease, as well as assuming increased costs for the hiring of racially concordant staff. And our results showed that it was cost effective. In a clinic with racially concordant staff compared to without, there was an overall increase of 50 quality adjusted life years and an overall increase in cost of $2,215. And when you spread that out per patient per quality, it leads to 44 cents, which is incredibly cost effective. In addition, there were no instances of decreased qualities, and there was a decreased cost of treating disease in all gender and age range models except for 80-year-old males and females, which was likely due to a longer lifespan in the cardiovascular disease state. When we did a sensitivity analysis, we saw, perhaps unsurprisingly, that racial concordance impact is the biggest influence on whether or not it was cost effective. In our study, based on previous literature, we assumed an impact rate of 1.25%, but in sensitivity analysis, we varied it from 0.01 to 2, and you can see that there's a big difference. However, even very small impacts are still cost effective. So typical thresholds for cost effectiveness analyses are $50,000 or $100,000. And at these thresholds, they would be met by any impact greater than around 0.06 or even 0.03% on outcomes. So small changes make a big impact. So in conclusion, our study finds that racially concordant staffing is cost effective and has tremendous potential to reduce cardiovascular disease mortality. And of course, there are many other reasons to increase diversity amongst medical professionals, but we hope that this study is the first step to showing that much more research is needed to investigate this potential in other dimensions, such as patient experience, communication, and reduction of unconscious bias. So thank you very much, and please feel free to direct any questions to my email, vling@umich.edu. Thanks so much.